Good afternoon, and welcome to the Senior Moment. This is Connie Clark with Home Helpers, and this afternoon in the studio with me, I have Dr. Joseph Abate with Dirne Clinic, and I heard him, Dirne Health Systems, and I heard him speak a week or so ago to a group, and it was a very interesting discussion. So I asked him if he would come on and talk about this, because I think it's something that touches every single person, either personally or somebody they know, and that is pain management. So welcome, Dr. Abate.
Welcome, Connie. Thanks very much. I'm glad to be here.
So first, tell me, what is the history of pain management? Tell me how we got to the point where we're at.
Well, in this country about 20 years ago, we became very interested in making sure that we had adequate pain treatment of patients who had cancer. And at that time, there were many physicians that were very reluctant to treat pain in patients with cancer because they were afraid of things like addiction. And so it became very important to treat those patients, and there was a push throughout the country to make sure that patients who had cancer and cancer pain were being adequately treated. Over time, pain assessment became known as the fifth vital sign, just as important as temperature and blood pressure. And so there was a push throughout the country to make sure that all patients were asked about their level of pain, and attempts were made to try to treat their pain adequately. And in all the hospitals, it was required to ask patients about their pain.
Yeah, I remember going in for something and then go, okay, rate your pain 1 to 10, 1 being not at all and 10 being excruciating. That's a standard question when you go in for a problem.
Exactly, and if you were in significant pain, it was expected that the doctors would treat you appropriately for that pain and try to reduce that pain level.
So where has all of that gotten us? I mean, now that doctors, that's a big thing they ask is your pain, and then they want to take care of that. Where has that gotten us to now as a society?
Well, what's happened over time is that we took what we learned about the treatment of cancer pain, and we attempted to move that to the treatment of non-cancer pain, the treatment of chronic painful conditions. And there are certainly many things that cause chronic pain, probably low back pain being the most common in this country. But about 20 years ago, the pharmaceutical manufacturing companies began to come out with different kinds of pain medications. And as a result, we have hydrocodone, oxycodone, morphine derivatives, fentanyl, Dilaudid, all sorts of pain, everything from mild pain relievers to very, very potent pain relievers. And I think over time, what we have learned over the past 20 years is that treatment of pain in non-cancer patients is probably a lot different from treatment of pain in cancer patients. In cancer patients, there's not much fear of addiction because many cancer patients have a relatively short lifespan, but in someone who's got a chronic condition where you're maybe treating them for 15 or 20 years, you certainly have to worry about the prospects of addiction or other side effects from the chronic pain medications. If you look back over the past 10 years, the rate of unintentional drug overdose from prescription painkillers has tripled in the past 10 years. And it's actually increased about tenfold from what it had been 20 years ago. And that's about the time that we started coming out with some of these medications.
And that's from people taking a medication, still being in pain, so taking more, thinking more is better kind of thing?
Right. There is a phenomenon of tolerance that especially happens in young people. And tolerance means that you need to take more and more of the drug to get the same effect. So it's very possible for people to start with pain relief, and after a while that doesn't work very well, so they need to take more, and then they need to take more, and then they need to take more, and they end up getting on very potentially dangerous levels because of that tolerance.
So what do you do? You're still in pain. It's not working anymore. What do you do?
Well, this is what's different about non-cancer patients, is that if you're treating a chronic pain condition, what we have discovered is that the only time that a person really gets significant pain relief is either when they start the medication or when they increase the medication. Using pain medicines for acute pain is very, very effective. It's very good. Using pain medicines for chronic pain is not quite as effective.
So that would be ongoing versus sudden incident of something.
Right. We describe chronic pain as being more than 90 days on a pain medication. So if you ask most patients how much pain relief they expect from a pain medicine, they will probably tell you that they expect somewhere between 60 and more like 80% of pain relief. They would like their pain to mostly go away. However, the statistics show that the average amount of pain relief people get over the long term is only about 20 to 30%. So there is a gap between the patient's expectations and what you can really accomplish with the medicine. And if the patient keeps expecting 80% pain relief and they find that the only time they get anywhere close to that is when they increase the drug, they will be tempted to repeatedly ask for more pain medicine. They get more pain medicine, they get temporary relief, but then the pain starts to come back again.
So what happens then? I mean, I know I have seen in some of our patients that are in pain that doctors just say, we're not giving you anymore. So then what do they do?
I think what's really important is making sure that patients understand from the beginning what they can expect from pain relief. If you have a person with a debilitating condition, say severe rheumatoid arthritis, every joint in their body hurts, most of those people come to the realization that they're not going to get 80% pain relief. They realize that they will get just enough pain relief to take the edge off and allow them to accomplish more than they could without the pain medicine. And they're usually satisfied with that or okay with that. They're realistic about what they can get. If patients are not satisfied with that and keep expecting more, they may get themselves into trouble where no amount is enough. And when people get on dangerous levels and they're still in severe pain, we realize that they probably have gotten to that point where no amount is going to be enough, and we need to re-educate them about what they can do. So when we treat patients who have chronic pain, we try to teach them that the amount of pain medicine you use should be based on how functional they are. If you improve their functionality with more pain meds, then that's appropriate.
And I know, like the ones that when they go to the doctor, the doctor refuses, they just go to another doctor. But that's not going to be as easy now.
There are not a lot of reasons to completely refuse a patient. I think it's more a matter of making sure that people stay in a safe range and making sure that they have adequate treatment and that their expectations are appropriate. I must say that many doctors have avoided treating pain patients because it can be a difficult population to work with. People who are in pain are not always happy. They can be somewhat desperate if they haven't gotten the pain relief that they expect, and it can be a very difficult population to work with to try to understand what they're experiencing. So there are many practices that I guess think that it's just easier to say, no, we're not treating anybody who's got chronic pain.
And that might be something like a general practitioner that's not their specialty, or whatever the person's condition is not their specialty. They wouldn't know what other direction to go.
There are a lot of drugs out there, and there are a lot of drugs with very serious side effects. So I would venture to say that many primary care practitioners feel that above and beyond a certain range is probably out of the scope of their expertise. what we found at Dirne Community Health Center is that it's probably best to separate the pain treatment from the medical treatment. So if a person has 5 medical problems and one of them happens to be chronic pain, it can be difficult to deal with all of that in one visit. So we have joined forces with Dr. Michael Whiting, who's a pain management specialist, and we like to separate the pain visit and the treatment of the pain from the treatment of their other medical problems. It is a subspecialty in its own right, and it probably should be based on the kinds of medicines that are used. Things like OxyContin, methadone, fentanyl, Dilaudid, those are very, very strong medications, and that is out of the realm of comfort for many primary care practitioners.
And they're very addictive also.
Yes, all of them can be addictive. Any narcotic can be addictive. There's even a non-narcotic drug called tramadol, and technically it's not a narcotic and it's not a controlled substance, but it works on the exact same pain fibers as the narcotics. So just like hydrocodone or oxycodone, tramadol can be very addicting.
You had spoke to our group about, and I want to go back to the pain management process you all go through, but you had spoke to our group about some laws that were enacted that physicians can see if someone is shopping around to doctors.
Yes, let's go back to the problem that prompted this all. The unintentional drug overdose rate tripled over the past 10 years. And those are from prescription drugs. These are not street drugs.
Not street drugs, but from your doctor.
Correct. The level of street drugs has remained about the same over the past 10 years, but the level of prescriptions has increased dramatically, and along with that has increased the unintentional drug overdose rate. In this country, 40 people a day die from unintended drug overdose. 40 people every day, 15,000 people a year. Now, I don't know of too many medications that you can come out with that would hurt 40 people a day, kill 40 people a day, and still be left on the market, but that is the case for prescription drugs. So obviously we want to help people, not hurt people. So the emphasis is on who's most at risk and how do we keep people out of trouble. So one of the things that we need to do is find out if somebody gets into trouble, they may look to several different sources to try to get narcotic medications other than their primary care physician, and that can lead them into more trouble. So most states in this country have a prescription monitoring program whereby they record every controlled substance that a patient fills.
And that's not your ones you go in there for the flu or anything like that. Those are the controlled substance to the narcotics.
Right.
Correct.
Only the
Okay.
ones that the FDA describes as being a
Okay.
controlled substance, a scheduled substance.
And so if someone was shopping around, so to speak, in Idaho, the physician could check to see if that is a pattern in other states, not only just in Idaho, correct?
Right. I mean, to us, where we start is we start looking at the Idaho Prescription Monitoring Program. And a clinic like ours has a lot of new patients who come in, and many of them have pain complaints. So if somebody presents and we don't know anything about who they've seen before or what their history has been, you can look at the Prescription Monitoring Program, and if you discover that they had been to 12 different emergency rooms in the past few months, that will tell you that that patient probably is in trouble. They're not getting what they're hoping to get, and so they're looking around at different places to try to get.
And you're
those
looking at
medicines.
this not for the criminal intent of it, but to make sure that you're taking care of the patient.
Correct.
properly.
This is for safety's sake, and you want to make sure that you are not treating somebody that's already being treated by somebody else. So sometimes the people will have several different providers, and some of them may be they may even have another primary care provider. So that's, of course, would be very important. You want to have one primary care provider and one source of the pain medication. So we usually ask people to go to one pharmacy.
So when someone comes to you in pain, what is the process you use? You talked about separating the medical conditions so that if someone has diabetes, you can have that diabetes discussion and not just talk about the pain that they're in, correct?
Correct. We like to make sure that whatever we do, we're going to do safely. So a part of that is needing all of the records that a patient has had prior to coming to your office or our office. And so we try to get all the records we can. We try to find out exactly what's being treated, what is the disease or what is the pathology that's being treated. We do run Idaho Board of Pharmacy reports on people to see what their past filling pattern has been for prescriptions. And we see if they've had any imaging studies in the past. Most people have issues like chronic back pain or chronic neck pain.
If there's a physical injury.
So we look to see anatomically what they have. We like to see if they've got an MRI that shows that disease, or if they've had a back surgery. We like to get those operation reports so we see what has been done. And we'll put together their past records. We'll ask them to fill out a risk factor survey, because there are certain risk factors that make it more difficult to treat some patients than others. And we'll ask them about parts of their past medical history. And behavioral health history is also important. There are certain behavioral health conditions that can increase the risk of using these medicines.
I want to go into more detail because you had gone into some really good detailed explanations about that process, but we're going to need to take a break, so we will be right back.
That's a perfect place. So what I'll do is, what I think we should do is talk about, I can get into the risk of overdose and the risk of addiction. Okay. Those are the two big things that can be a problem. So I'll give some statistics about overdose, and then we'll give some statistics about addiction. Okay. And the high-risk categories.
Okay. You ready? And we're back. Welcome back to the Senior Moment. This is Connie Clark with Home Helpers, and I have Dr. Joseph Abate with Dirne Community Health Systems. And we've been talking about pain management and narcotics that are used for that purpose. And there is a new program over at Dirne relating to pain management. And so that is kind of the reason why I asked Dr. Abate to come talk, because it's a program I didn't know anything about, and I think it's one that's kind of unique in our area. So Dr. Abate, tell me, if someone comes to you in pain and you had talked about separating their medical conditions, what do? You said you checked the pharmaceutical record to see if they're shopping around or if they're in trouble. What else do you do?
Well, there are certain questions that we like to ask, and they're part of we use something called the opioid risk tool, and it is something that assesses the potential for risk of misuse or abuse. Who is likely to get into trouble? And there are certain. Well, let me talk about the things that can make a person more at risk for becoming perhaps addicted or having difficulty using those. If you have a behavioral health diagnosis such as post-traumatic stress disorder, ADD, bipolar disease, borderline personality disorder, those people are at higher risk. If you've had a past history of family of drug or alcohol abuse, no matter how long ago, even as a teenager,
so it wouldn't necessarily be you.
Either a past or a family history, both of those increase the risk.
No, I mean you wouldn't have it. It could be your father or your grandfather or something like that.
That's correct. Okay. That's one of the factors. That's one of the risk factors. Let me give you some statistics. The overall risk for addiction using narcotic medications is 3.3%. Which sounds relatively low. However, if you have a personal history of drug or alcohol abuse in the past, no matter how long ago, even as a teenager or even in high school, that increases your risk of addiction to 50%. If you have a family history, not yourself, but if you have a family history of drug or alcohol abuse, that risk is 50%. If you have one of those diagnoses I mentioned before of PTSD or bipolar disorder or ADD, that risk is 50%. So that's a very significant increase in your potential risk for getting into trouble.
So if you've had a number of those, that just stacks it up.
If
as
you
far as your risk factor.
If you have a personal history of drug or alcohol abuse and a family history of drug or alcohol abuse and one of those psychiatric diagnoses, your risk of addiction is greater than 90%. So those people are almost guaranteed to become addicted if you get them on medications for more than a month. And so the important thing is to be able to know that before you prescribe and to have a very frank conversation with the patient. And you want to be sure that you're treating something that you can see, something that's definitely objective, and you want to know that you've got a definite exit strategy, because those people can get into trouble in as little as 21 days.
Wow. And when you started talking about all those things, I started thinking veterans, because everybody knows that's where my passion is. And if you've got a veteran who came out of the military and started numbing themselves because of what they'd gone through, and now something has happened to them, and they've got PTSD and they're in pain for something, that's just going to stack them up. And if their father was in the military and came home with the same issues and drank to numb themselves, that's another stack. So our veterans are really at high risk for addiction to pain medications.
Veterans are at very high risk. As you know, the rate of PTSD with our veterans coming out of Iraq is very high. I think I heard it somewhat in the 60% range or something of that order. And so it can be very difficult to re-enter civilian life after you've been in the military. And the VA treats some of those conditions, and the VA also treats people with narcotic therapy. Now, their records are not always available to us, and even their pharmaceutical records are not always available to us. That's not part of the Idaho Board of Pharmacy. So we have to be very careful with the veteran population, because if someone comes to us seeking pain medications, we'd like to know whether or not they're being treated in the VA system, so that we're not duplicating services, we're not duplicating prescriptions. But that is a very high-risk population, and we like to do all we can for our veterans. We've got caseworkers at Dirne Community Health Center who work very closely with the VA, and the VA comes into our institution, and we've got caseworkers who really love working with the veterans and try to make sure that they're treated and treated safely.
That's interesting that when you start talking to someone about their pain management, one of the things you talk about is the exit strategy. And I'd never heard that before until you and I had started talking.
Well, let me talk a little bit about neuroplasticity. Neuroplasticity is a term we use which means that there are certain things that can change the way the brain functions. And narcotics is one of these things. It can change the way the brain perceives pain. I liken it to, if you walk out into the daylight, it's usually not a big deal. But if I put you in a dark room for a long time and then you walk out in the daylight will actually hurt your eyes. Well, if you're on pain medicine for any significant period of time, you block your pain fibers. And if you block them chronically, if you're taking your pain medicine 4 times a day, chronically block those pain fibers, and then you take that medicine away, you have unblocked those pain fibers, and you will be very hypersensitive to any kind of sensation. So things can actually feel more painful. Now that a characteristic of neuroplasticity, that change can take place in as little as 21 days. So if you have a person that, say, has an operation and you put them on pain medicine, you give them 30 days of pain medicine. You know, the average person after, say, a knee replacement may take pain medicine for a week and then they're done. They'll go to rehab, their knee still hurts, it will hurt in rehab, it will hurt when they go home from rehab, but they understand that that's a part of the healing process, and so they deal with it and they're done with their medicines after about a week. If you have a person that really does not like pain or doesn't tolerate pain very well, they may continue to take that medicine, if they have it, every day, 4 times a day, until they're done for 30 days.
Just in case it hurts.
Because it still does hurt.
Okay.
I mean, the healing process does hurt. So if their expectation is that they're going to make that pain go away, they may continue to take that medicine every day for 30 days. It's been said that the first call for the refill after 30 days is your first red flag. If somebody calls you after a routine sort of an operation or after an injury that should be healed, and they say, I'm still having pain, I need more medications, that may be your first sign that the patient's in trouble.
And that would probably be the best time to put something in place to wean the person off versus months and months of doing it.
That's a good time to consider the exit strategy.
The exit strategy.
And that's a good conversation to have with that patient. And I actually like to have that conversation before the patient gets started on medications, because once they're in that position, it's pretty hard to explain to somebody that they're still going to have pain, and you expect them and almost want them to have some pain because that's part of the healing process. I think it's very culturally unique in America that we think that pain is a terribly bad thing that's to be abolished whenever it occurs. And in reality, pain is sometimes a very good warning sign that tells us we shouldn't be doing something. So I don't like to take a patient with back pain, put them on lots of medicine, and then have them go out and do things that hurt their back even worse because they are somewhat numbed by the back pain.
And you had spoke about having them do other things like physical therapy and that sort of thing that would alleviate the pain versus the drugs.
Right. In most other countries, there is a great emphasis on things other than medications in order to try to deal with that pain. Non-steroidal anti-inflammatory agents, physical therapy, certain exercises. Some people use acupuncture in the Oriental countries, and it's also popular in this country. And then local therapies to try to deal with that, ultrasound therapies, heat therapies. But those are always very important. Some patients aren't terribly motivated to do that. They believe that the pill is the easiest thing to do. It doesn't require any cooperation. It doesn't require any effort. It's just, please let me have that medicine so that I don't have to have any more pain.
No behavior modification.
Well, I think there are some certain things that can keep a patient out of trouble rather than just have them ongoing pain management, because once they get beyond 30 days, it's very hard to convince somebody that taking the medicine away is actually going to be better for them.
One of the things I had brought up to you after your discussion was seniors. And one of the things that always concerned me was my mom. She had a hip replacement, and she was still in pain, but she still had her pain pills, and she would take those. So what do you do when you have somebody in their 70s, 80s, 90s who is continually taking pain medication? Do you put them through something that weans them off it? Do you let them continue knowing that, they're that old? What do you do about that?
Well, there are a few parts to address in that question. One is, what is the risk of these medications in the senior population? And there certainly is a risk in using narcotics in the senior population. And it's also true for sleeping medicines and anxiety medications. The senior population is going to be more sensitive to these medications. They've got less brain reserve in terms of how clearly they think. So confusion, falling, fractures, injuries, those are all increased with these sorts of medications because they will dull the senses of that population. It's not necessarily a bad thing if somebody has some medicine left over from something and they get another acute injury and they take a few pills. But I think if you're talking about somebody who had an operation that was long ago healed and it's 3 years later and they're still taking medicine for that, that needs to be carefully looked at. It may be that they have an ongoing reason for requiring medication, but it also may be that they've discovered that every time they try to stop the medicine, what they have is withdrawal pain. And if what they're feeling is withdrawal pain, they will learn by trial and error that if you stop pain medicine and you have withdrawal pain, the way to make that go away is to restart the medicine. And so in their minds, no medicine means pain, and being back on the medicine means that the pain gets better. So they will continue that pattern unless somebody helps to educate them and tries to assist them in tapering or possibly even discontinuing.
How do you know the difference between withdrawal pain and the original pain that you took the medication for?
You don't, and that's the problem, and that's very hard to explain to a patient. Almost everybody who's on chronic pain therapy will have withdrawal pain. Almost everybody. So you can expect that if they stop their pain medicine, especially suddenly, that they will have pain. I can take a 16-year-old healthy young male with no problems whatsoever and put them on hydrocodone for 3 months or 6 months, and when I take them off, everything in their body will hurt. Every bone, every joint, every muscle. They describe their skin as being on fire. It hurts. That's what withdrawal is like. Now, I can look at that 16-year-old and say, you're perfectly healthy, so you don't need these medicines, so we're going to not give them to you anymore, and you will be fine. Go ahead. That's a harder conversation to have with somebody who has had a back issue or who has a neck issue or who has had knee surgery. And when they stop, that pain may focus on the thing that was originally injured. And it's very hard to get a patient to understand that they may actually be better off on less medication, or they may be able to tolerate their pain that they have on no medication, because that pain truly does get magnified over time, especially if they've built up to very high levels of narcotics.
If they, just let me talk about her as an example, it was her hip. Well, if she started having pain in her hand for some reason that wasn't the original reason, when she went off of it, would both things start hurting?
Yes, they would both. They would start to hurt. And there's another phenomenon known as hyperalgesia, especially in patients who are on fairly large doses of medicine. Hyperalgesia relates to that unblocking of the pain fibers I talked about. And in that condition, even minor injuries will result in what seems to be unbearable pain.
So you could have done something that caused pain during that time period, but wasn't a major thing.
Right.
It's really going to hurt when you get off it.
Right. So I may see a person who's on very large doses of narcotics because they have chronic back pain, and they may twist their ankle. Now, normally a twisted ankle is uncomfortable and painful, but it's not unbearable. But to those people, it may feel absolutely unbearable. They may feel that they need to dramatically increase their medicine even more than they did before. And sometimes what happens is you get an acute injury, somebody increases the medicine, and they never bring it back down to the pre-injury levels. And so over the course of 5 or 6 or 7 years, a series of acute injuries, and they end up on very high doses of medicine that they can't get off because the withdrawal is too severe.
What about someone with fibromyalgia, where their entire body feels like it hurts?
Yes. Again, we've learned the hard way that fibromyalgia is not really an indication for narcotic therapy. Unfortunately, many people have gotten on narcotic therapy because of fibromyalgia, and there have been pain clinics, and I put that in quotes, pain clinics across the country that have put people on fairly large doses of narcotics for fibromyalgia. And in the long run, just like many other chronic conditions, in the long run, that will make the patient worse. It's not a good treatment for migraine headaches because you get rebound migraine headaches. It's not a good treatment for fibromyalgia. That just puts people in a condition where they absolutely have to have these medications to feel normal, and anything else feels just horrible.
Good grief. Well, I'm going to take another break, but I want to continue this discussion, and one of the things I want to talk about is other controlled substances. And you had mentioned about the number of people a day that die that we know of from overdose, and asked some questions about that. So we will be right back.
That will never, I mean, you'll never know. You'll never be able to know that number
Yeah.
or the incidence of that
So it
happening.
might be even greater than what we think.
Yeah.
Okay.
Mm.
All right, you ready?
Mhm.
And we're back. Welcome back to the Senior Moment. Again, this is Connie Clark with Home Helpers, and I have Dr. Joseph Abate, and he is with Dirne Healthcare. And we've been talking about pain management and narcotics and the epidemic, I guess we could say, here in our country on the number of overdoses from prescription medications that people have. And one of the things I wanted to kind of bring up, we had on here several months ago a couple folks talking about suicides. And one of the discussions that we had, which really surprised me, was the fact of the number of senior suicides and how they are more proficient in actually completing the act than younger people. And we had talked about seniors either withholding medications from themselves or saving them up and taking a lot of them. And if a senior is on pain medications, this is something they could do. And it wouldn't be part of the statistic because we would never know if a person died in their sleep and it was from an overdose of pain medications. And that's really kind of scary. You know, I relate a lot of these things back to my mom, and she was on pain medications, that's for sure. And one of the other things she was on was sleeping pills, and you had mentioned that. And my mother could never go to sleep without taking a sleeping pill, but yet she was still up till 2, 3 o'clock in the morning. Would that be the same thing where the body becomes, it doesn't work anymore on them?
Sleeping pills and anxiety pills are very addicting. In Canada, they don't allow you to use those drugs for more than 30 days. They're very addicting. And when you talk about unintentional drug overdose or perhaps even intentional suicide, the most worrisome combination that we see is a patient who's on pain medication plus an anxiety pill plus a sleeping pill. And the other two drug categories that can increase the risk of a narcotic are muscle relaxants, certain muscle relaxants, and alcohol. So a setup for a drug overdose death, unintentional drug overdose, is somebody whose pain is worse than usual, so they take more of their pain medicine than usual, and they can't get to sleep because they're in so much pain, so they take their sleeping pill, and they've been really anxious about their pain, so they take their anxiety pill, and perhaps they even will add a drink on top of that. And that is a very toxic combination. Now, the truth is that people on chronic narcotics, none of them sleep well. It really messes with the ability to get normal sleep. It disrupts the sleep pattern. So it's very common for a patient on chronic narcotics to go to the doctor and say, "I'm not sleeping well. Can I have a sleeping pill?" And many times they will get that sleeping pill. Ambien is the most common. It's very, very common. And our country seems to feel like Ambien is a perfectly benign pill, and there's nothing wrong with it. But the truth is that Ambien works like the benzodiazepines or the anxiety drugs. It works like Valium. It works like Xanax. It works like clonazepam or Klonopin. Works on the same pain fibers. So the truth is that long-term Ambien does not help insomnia. It actually makes it worse. What happens is in the long run, you still can't get to sleep, but you absolutely feel that you need that pill to try to start to get to sleep. And that's great if you sell Ambien, but it's not very good if you're the patient who has insomnia. So we're very concerned about people who come in with what I call the toxic triad. If they're on pain pills and anxiety pills and a sleeping medicine, I know that they're in that process where they're just trying to treat the symptoms that are mostly caused by the pain and the narcotics in the first place.
And that's interesting that you said that, because my mother would take a pain pill, especially if she was going to do something that involved walking around, like shopping or something. And then she would take her sleeping pill to go to bed. And she had started within the last couple years of her life drinking a glass of wine with that. So the combination of those things could have been lethal for her.
Yes, and the combination of an anxiety medicine or Ambien with alcohol it's more than additive. It can be really very powerful. And that's a very dangerous combination for a lot of people. Now, people who get on these medications long term, they can build up to very high doses and have a very high tolerance. But if you have somebody that some days may only take 2 or 3 pain pills and other days may take 5 or 6, and that day they happen to take their sleeping pill and some alcohol, that could be a deadly combination.
What does that do to the organs in your body?
Well, it's not so much that it changes the organs in the body. I mean, certainly you can have some issues that occur with your liver if you're taking a lot of Tylenol along with your pain pills. But the biggest problem with overdose is you have respiratory depression. People stop breathing. That's how an overdose occurs. And here's the problem with pain medicine. The pain relief does not last as long as the depression of the respiratory drive. So your breathing doesn't come back to normal until long after the pain comes back.
So what does that relax your muscles from breathing?
It has a central nervous system effect, so that in the part of your brain that says you should be breathing, it slows that down. And so if a person is prone to taking medicine more often than they should, and they're trying to chase after their pain, make the pain go away, or to use the lingo that we used to use for cancer pain, staying ahead of the pain. They used to encourage people to take the pain medicine before the pain came back so that you could stay ahead of the pain. That's not a good concept for people with non-cancer pain. But if you're taking pain every time, if you're taking medicines every time the pain comes back, trying to make the pain go away, the respiratory drive may get more and more and more shallow as you keep taking that medicine, and ultimately you stop breathing, and that's how an unintentional drug overdose occurs.
So if you were doing something strenuous, that might be really hard because now you're breathing more, but you're really not breathing more because your brain's not telling you?
It's not so much a problem during activity. It's really a problem during sleep or when somebody gets terribly sedated.
Goodness. What other kind of problems do we have with controlled substances? You had mentioned pain and sleeping pills. Anti-anxiety like Xanax. Now, I know kids, that's something on the black market, is kids buying Xanax. What does that do to us?
Well, let me just mention a few anti-anxiety pills that are very common in our country. Valium is one of them. Xanax or alprazolam is the generic name. Ativan or lorazepam. Clonazepam or Klonopin. Transine. Those are all anti-anxiety agents. Now, what we have found in what Canada and England have discovered is that those drugs are incredibly addicting. And again, after about 30 days, they're fine to use in acute anxiety states. But after about 30 days, you have suppressed certain fibers in the brain. And when you take that drug away, the anxiety becomes overwhelming. And it's probably more difficult to get a patient off benzodiazepines than it is to get them off narcotics, because the anxiety, the insomnia, the racing thoughts that people get coming off benzodiazepines can be just incapacitating. And in a rare case, sometimes people can even get seizures. And so there have been some fatalities in people coming off benzodiazepines abruptly. So you may have to wean patients off that drug over a prolonged period of time. Anytime from 3 to 9 months, if they've gotten onto high doses of that. But just like the Ambien long-term makes insomnia worse, the benzodiazepines ultimately long-term make anxiety and panic disorders worse, except in the very rare case. So if somebody started off with feeling a little anxious and getting on some Xanax, and they went from once a day to twice a day to 3 or 4 times a day and higher doses, they often are still relatively incapacitated by their symptoms, and now they're addicted to those drugs as well. And it's very hard to get people off benzodiazepines. It is the favorite drug of people who are withdrawing from narcotic medications. It is the favorite drug of people who have alcohol issues. It works on very similar fibers as alcohol does. So in our experience, we call it alcohol in a pill.
And so you're all right. So if it's harder to get off these than, say, cocaine or something like that, do they have facilities that someone could go to do that? Or because it's a legal drug, they don't have rehab places for people to go to?
It's that's very difficult to do a rapid detox from a drug like that. You can fairly rapidly take somebody off narcotics, and it may be uncomfortable, but it's not dangerous. But to do a rapid withdrawal from benzodiazepines can be potentially harmful, and it's certainly uncomfortable. It's really not complicated. You can just take that medicine and you can just taper it down very slowly, just maybe 5% a week or every 2 weeks, and get them off over the course of 3 months, 6 months. But the patient has to be willing. That's the problem. And so the patients feel uncomfortable as you're doing that.
For a long period of time.
Yes. And in their mind, they think you're withholding the thing that they need, because they're feeling those symptoms now that you're unblocking what's been blocked for very long. They feel those symptoms again, and they really want you to give them back that medication that they thought was making them better, because short term it does indeed make them better, but it's an addiction. It's just like somebody who's been out without cigarettes for a long time really would like a cigarette. Somebody who's been without alcohol for a long time would really like to have a drink, but that's not really the right thing to do for those people.
And we see an increase in our population on Oxycontin use, and so if you've got somebody that's getting it illegally, then you've really got a whole nother bag of worms, because you don't have that history to go back and look at to see that they filled these prescriptions and that sort of thing.
Right. We drug test everybody that comes in. I think part of a sensible pain management program is that anybody who comes in, the first thing you do is you get a urine specimen and you drug test them. And we're not doing that because we think everybody's a criminal, but we're doing that because you may not know what that person is truly taking. So a perfectly normal-looking person with a perfectly reasonable story, you may find that they're getting OxyContin off the street, or you may find that they're actually using methamphetamines. And it would be very dangerous to just give that person prescriptions and think that you know how to treat their pain, and in fact you're putting them at risk. So everybody gets a urine drug screen, and we look for drugs of abuse or drugs that they have not been prescribed. And not everybody's a criminal who walks in with a drug that they weren't prescribed. It's estimated that 75% of the people who are using drugs they're not supposed to get them from a relative or a friend.
Someone trying to help.
They borrow them. They ask for them. They buy them. They steal them. They're not prescribed to that person. But that's about 3/4 of the people who, people don't just necessarily go to the street corner and find the drug pusher who's doing that. There's a lot of sharing of medications that goes on that's really not appropriate.
So if somebody has problems with pain and they feel that they're in trouble, they can come to Dirne and not be afraid that, they're going to be drug tested and thrown out because they've bought something off the street or something like that, correct?
The thing that is most necessary is for people to be honest. And if someone comes in and is honest about their usage and is honest about the fact that they think that they may be in trouble, we can certainly help them. Anybody can help that sort of a person. The difficulty comes when somebody is not being totally honest, and they begin to tell you a story that does not make any sense. And the more you ask about the story, the less it makes sense. And then at that point, if there's no trust in the relationship, it's very hard to trust that you can help that patient. You're basically giving them prescriptions, and they're walking out the door with your medications, and you're not really sure what you're doing with that. There are ways to help people that are in trouble, and I think there are far more people who have gotten into trouble, and they may not know it, or they may be afraid to tell you that they're in trouble. There are far more of those people than there are people who are maliciously trying to get away with something.
So if you think you're in trouble, you can go in and talk to you at Dirne and start this process.
Exactly. And how do you know if you're in trouble? If you use your medicine more often than prescribed, if you're running out of your medicine early, if you find yourself going to emergency rooms or urgent care looking for medicine in addition to what you're getting from your primary care provider, if people have expressed a concern about how you're taking your medication, those are warning signs. If you take your medicine for reasons other than pain relief because you're having a lot of stress or you don't sleep well, those are signs that you may be in trouble. That's a time to talk to your doctor and say, what are my options here?
So if someone is in trouble or wants to find out more information, they can call Dirne. Their number is 415-0292. Do they need to ask for a particular department or?
That number, actually, the main number at Dirne Community Health Center is 292-0292. So if they call 292-0292, they can ask for scheduling. Now, I can tell you that the schedulers will ask people if they're on pain medicine, if they're on anxiety medicine, if they're on sleeping medicine. If they are, then we're going to want all of their previous records so that we can evaluate what's the best thing for them. We can't have somebody just come in off the street with no records, tell us a story, and tell us that they're on 3 controlled substances and we need to refill them. That's not the way it works. It doesn't happen. But if somebody will make an appointment and will get us the records, we're happy to look at those records, find out what's being treated, and if they, especially if they think that they're in trouble. If they have a legitimate problem but they think that they've gotten into trouble with medicines, we've got a pain management expert who knows very well how to help people with alternative therapies, with tapering schedules. I've tapered so many people. It's been very rewarding to find people who are not doing very well on large doses of medicines, and if they trust me enough to taper them down on medicines, they find out that they actually have an improved quality of life. They're on less medicines, and they really don't feel like they're that much in trouble as they were.
Well, this has been very interesting because, like I said, after listening to you speak the other day, it brought to the forefront a problem, and then the more I started thinking about it, the more I could relate to my own family and things that I had seen with my mom. And, it's sad because I think back of all these things that I could have done or ways I could have helped her, and now she's gone and I can't. I wish I'd have known all of this back then, that we could have helped her with that.
Well, I think the truth is that 10 years ago, the state of the art was to use these medications as much as we could to eliminate people's pain. And there was a true belief that we could make people's lives much, much better if we just used enough medication. I think that once we saw the overdose rate go up dramatically, we realized that this was a double-edged sword. And so your mom probably had state-of-the-art therapy at that time.
Yeah, I'm sure she did. She had no problems getting them.
Yep. And that was the way things were done. And now we have a very large percentage of our population on medication, and we need to decide what to do with that. The United States uses 99% of all the hydrocodone in the world and 83% of all the oxycodone in the world. That's what's consumed by the United States.
And we don't have that same percentage of population of the world.
And I don't think we have 99% of the pain in the world.
No.
So we have a very culturally different approach to pain and trying to eliminate pain. And I think as a result of that, many people are in trouble, and we'd like to help those people that are in trouble.
Well, if you think you might be, or you know someone who is, this is an excellent program for them to get involved in to put their health back in the right direction. And I thank you so much for coming on this afternoon with me, Dr. Abate. You've brought up a lot of different ideas, and I think the folks out there are really benefiting from this information.
Thank you very much.
Thank you.
My pleasure.
And you all have a wonderful rest of your afternoon. Good day.